Hi, good evening. I'm Dr. Rajiv. Let's discuss on this topic DPP4 inhibitors and SGLT2 inhibitors combination approach for type 2 diabetes management in high cardiovascular risk population. Indian diabetes, as you know, like we are like 2 decades earlier, we have this diabetes in India because we are very prone to it, right? So even the micro and macrovascular complications appear very early in Indian patients, right? So we also know that that there are other risk factors like smoking, hypertension, overweight, obesity, and even this LDL. These all increase very much, and they are associated with diabetes, and overall it leads to the metabolic syndrome. So what is the unmet need, right? So the tendency for earlier onset of type 2 diabetes in Indian population suggests that accelerated risk of developing complications. So there is a high burden of poor glycemic control was observed in Indian patient in the TIDE study, which has this 55,000 of the patients, and 76.6% of the patient has poor glycemic control. Obesity and hypertension, as well as like established comorbidities for diabetes in real world Indian settings, right, overall leading to the metabolic syndrome. The need of early treatment initiation and intensification to achieve and maintain the recommended glycemic control is the required for this hour, right? Now the aim is to reduce the microvascular and macrovascular complications. Okay, so we are going to discuss these two topics, two drugs, class of drugs, right? So SGLT2 inhibitors and DPP4 inhibitors. SGLT2 inhibitors have a indirect pancreatic effect. It increases the beta cell sensitivity, increases the glucagon. It has increase in the glycosuria, so it decreases the glucotoxicity. And like DP4, like dual pancreatic effects, it increases the insulin secretion, and it decreases the glucagon. As you can see, they have this incretin effect which has increase in the GLP-1 and GIP. Now important thing is that you can see that DPP4 inhibitors and SGLT2 inhibitors, both when combined, can nullify this change in glucagon. Also they have got a effect on this hyperglycemia, right? And SGLT2 inhibitors has a decrease in the weight and systolic blood pressure, and DPP4 inhibitors has a weight neutrality overall, right? So with the combination of Vildagliptine and Dapagliflozin, so is the duo really good for cardiovascular and renal like benefits it has? So we'll see about it, right? So let's see when we combine. So we are going to discuss a meta-analysis, and there are like it is an evidence-based medicine which is we are going to discuss. So like we'll go for the PICO format. This PICO format is population, intervention, control or comparator, and then outcome, right? So cardiovascular and heart failure safety profile of Vildagliptine. So first we are going to discuss about the Vildagliptine. Here we're going to discuss like see this MACE over here. You can see in the first line over here, MACE. Now this MACE is nothing but major adverse cardiovascular event, and it is a very important MACE term. Now you can see this patient population was around 17,000. There is a number of patient was there, right? The intervention was given was Vildagliptine, okay, and the comparator was so the patients, the high risk patient with type 2 diabetes mellitus, such as those which have congestive heart failure and a moderate severe renal impairment, right? You can see a MACE occurred in 83 patients. It was 0.86 with Vildagliptine treated patients, and 85, that is 1.20% comparator treated patient, right? So we can also see that nearly the confirmed heart failure cases were nearly same for both Vildagliptine and comparator group arms, right? So in this meta-analysis, which we can see over here, that Vildagliptine is not associated with an increased risk of adjudicated of MACE, okay, relative to the comparators, okay. So Vildagliptine has a decreased risk of it has has a decreased risk for the MACE to occur. Okay, and there is a no significant increased risk for heart failure in the vildagliptin treated patient were observed. Similarly, one more study was done. Okay, we are going to discuss another one. Here the patient population was around 515 patients were taken this of type 2 diabetes with moderate and severe renal impairment. Okay, with the GFR of 30 to 50 or less than 30 ml per minute per 1.73 meter square. Right, now the dose was 50 milligram QD, right, in patient with the type 2 diabetes. Right, now after 24 weeks the between difference treatment difference is and the adjusted mean change in the A1C was minus 0.5 1%, and for the moderate was around and for the moderate one, and for the severe it was minus 0.6 plus minus 0.1%. So vildagliptin shows statistically and clinically significant decrease in the A1C in patients with moderate and severe renal impairment as compared to the placebo. Right, so these are the two we have discussed about vildagliptin. Something about dapagliflozin, its effect on the cardiovascular events. We are going to discuss this declare TME58. So we can see the spelling declare TME58 dapagliflozin effect on cardiovascular, right. So there are the then events, right. Then the TME is thrombolysis in myocardial infarction 58, right. So this is declared TME58. Now the patient population was around 17,160, and type 2 diabetes with an APG1AC was 6.5 to 12% was used, and or we can see this risk of atherosclerotic cardiovascular disease was high in those patients, right. The dose, the intervention was dapagliflozin 10 milligram daily, and here we can see this in the two graphs over here. So you can see the placebo over here, and the dapagliflozin down below, right. Similarly here also in the weight also. So what we see that the patient in the dapagliflozin group had lower glycated hemoglobin levels throughout the trial than patients in the placebo group. Also in the weight, the least squares mean a difference between the groups in the reduction in the weight during the trial was 1.8 kg. Right, so overall dapagliflozin decreased the weight as well as decreased the HbA1c of the patient. Now we can see in the systolic blood pressure, diastolic blood pressure, and as well as in the cardiovascular diseases risk, we can overall see that the declared TME58 is the largest SGLT2 trial which included a broad representation of primary and secondary prevention patients. Dapagliflozin is superior to the placebo in improving the glycemic control, as well as dapagliflozin reduced the CVD and HSF and neither increased nor decreased the MACE. Okay, so it is very important. So the differences shows that there was a decrease. So declared TME58 is really important. Now overall we can see there in the declared trial that is a DAPA was used, and Canvas and Canvas R trial canagliflozin was used, and empagliflozin was used in the EMPA-REG trial. Here we can see in the primary prevention management nearly 60%. So the maximum number of patients were also used, as well as 60% reduction in HbA1c, and in the primary prevention, right, in the primary prevention. So in the primary prevention, the multiple risk factor for the cardiovascular disease, 60% of the reduction is seen in the dapagliflozin, as well as in canagliflozin was only 34%, and empagliflozin nearly has nil. Dapagliflozin is the only SGLT2 inhibitor with a CVOT with a majority primary prevention patient population. Now dapagliflozin in patient with chronic kidney disease, it was another trial of the DAPA-CKD. The patient population was 4,304. The patient with or without type 2 diabetes who had an eGFR of 25 to 75 ml per minute, like they have a urinary urine albumin to creatinine ratio of 200 to 5,000. Like the dose was also this 10 milligram daily, and the primary outcome The outcome was good, very very good. So in patient with CKD with or without diabetes, the risk of composite of a sustained decline in the estimated GFR of at least 50% end stage kidney disease or death from the renal or cardiovascular causes was significantly lower with the dapagliflozin than with the placebo. Okay, so dapagliflozin overall has a reduced risk of the reduced renal and cardiovascular causes causing the CKD, right? So now we will be comparing about the gliptins. We'll have a comparison in the efficacy in the gliptins. You can see a study over here in the randomized controlled trial of 83 randomized controlled trial was used, and a systematic review was done in the PICO format. So let's see in the PICO format what's there. Patient population in the type 2 diabetes and inadequate glycemic control receiving any pharmacological anti-diabetic treatment. That was the patient population. Intervention was any DPP4 inhibitors, allogliptine, linagliptine, saxagliptine, sitagliptin and vildagliptine, or like a pioglitazone was used in the treatment of the type 2 diabetes as a monotherapy, dual therapy or a triple therapy. The comparator was any pharmacologic anti-diabetic treatment or a placebo or a standard of care for diabetes like metformin. Outcome was HbA1c. We have will measure an FPG, that is the fasting plasma glucose, LDL, HDL, triglyceride, body weight, hypoglycemia, and serious adverse event were actually measured. Similar efficacy and safety for the DPP4 inhibitors as treatment for type 2 diabetes, either as monotherapy or combination therapy, was observed in this systematic review, right? Now, it is a very important trial, this J Victoria study. J Victoria study is very very important. We can see this comparison of vildagliptin twice daily with sitagliptin once daily using the continuous glucose monitoring. Okay, it was a pilot study, it was a crossover pilot study. Okay, the 20 patients were used. Now type 2 diabetes patient, this 20 diabetes patient with poor control of the HbA1c, that is 6.5 to 9.5%, in spite of diet and exercise therapy for 1 month or longer, with or without oral anti-diabetic treatment. So overall we can see that they have a like higher level of DPP4 inhibition over 24 hours in patient taking vildagliptin. So vildagliptin overall is excellent, and compared with the patients taking sitagliptin. Okay, so vildagliptin is much better controlling this DPP4, right, and inhibits the destruction of the incretin, which enhances the endogenous insulin secretion and thereby improving the MAGE. Now this is MAGE. Now this MAGE is nothing but mean amplitude of glycemic excursions. We have discussed about MACE. Okay, so MACE was something major adverse cardiovascular event, but this is MAGE. This is the mean amplitude of glycemic excursions. Okay, so these 7 parameters were actually observed. We'll discuss these 7 parameters. Mean 24 hours blood glucose was taken. Mean amplitude of glycemic excursions were done. FBG fasting blood glucose level were done. Highest postprandial blood glucose level and the time was measured. Increase in the blood glucose level after each meal was done. Area under the curve for blood glucose level more than 180 mg per deciliter was done within 3 hours after each meal. Area over the curve for daily blood glucose level was less than 70 mg per deciliter. Now these were the things which we have seen in this study. Okay, and overall what we have seen was vildagliptin is much better. A single twice daily vildagliptin is much better efficacious than with the sitagliptin taking once daily. So the continuous glucose monitoring shows that 24 hours glucose, MAGE and highest blood glucose level after supper and hyperglycemia after breakfast were significantly lower in the patient with type 2 diabetes mellitus taking vildagliptin than those taking the sitagliptin, right? Now there is another study which is very important, is the effects of 50 mg vildagliptin twice daily and 50 mg sitagliptin once daily on blood glucose fluctuations evaluated by the long-term self-monitoring of the blood glucose. Now the patient population was only 32, So that was the type 2 diabetes which receiving the patient taking the sitagliptin at 50 milligram per day. Okay, that is then approved in the Japan, and vildagliptin 100 milligram per day for more than 3 months with an HbA1c in the range of 6.2 to 8.3%. Now here we can see this is vildagliptin and this is sitagliptin, right? So overall you can see over here like it is also crossover study. You can see like it was crossed, like once they were giving vildagliptin and then they were giving sitagliptin and there was a gap in between. Now vildagliptin 50 milligram twice daily showed significant and potent effects compared with sitagliptin 50 milligram once daily, both on daily blood glucose variability and improvement in the glycemic surrogate markers like HbA1c, glycated hemoglobin, and 115 Ag in Japanese type 2 diabetes. Now the take home message, we can see that like this, some points are very important, like vildagliptin and dapagliflozin fixed dose combination exerts additive effects on the hyperglycemia, and that we have seen in the mechanism of action. Beneficial effects on glycemic control and other cardiovascular risk factors are very important. Now they do not produce hypoglycemia or a weight increase, so they actually neutralizes or decrease the weight, right? The guidelines, as the guidelines say, that early combination therapy with SGLT2 inhibitors and DPP4 inhibitors is recommended as part of the glucose lowering regimen, independent of A1C and consideration of the patient specific factors, right? So this is very important. We can say the combination of both the drugs, it will be used as much early in the diabetes patient, in a patient which have a highest risk of cardiovascular risk due to this type 2 diabetes mellitus. Okay, so thanking you for listening patiently. Okay, so till then, bye.